Okay, so it is 7:30, so it is time to kick off February's film reading session. I hope all of you have had a pleasant day, and I hope you will enjoy going through this evening's cases. For those of you who are new to these sessions, just a very brief introduction. My name is Ian, and I'm a radiologist. I graduated from the RVC back in 2004. I went on to do an internship at the RVC. I spent several years in first opinion practice, where I got my IR certificate in 2009, and finally got my imaging residency in 2013, again at the RVC. I completed that in 2016 and got my European diploma in 2018. And these days, you can find me at London Veterinary Specialists, which is the only multidisciplinary referral hospital in central London. And if I can help you guys at all with any of your cases and any of your imaging needs while you're working up those cases, whether it's to have a chat about which imaging modality would be most suitable or to have a chat about some radiographs, then either drop me a line via the email or give me a call at the clinic. So we are going to use some online polling software this evening, should you choose to participate. We are going to discuss these cases together, so hopefully some of you will be happy to present your radiographic reports for each of these cases. They've been available for the last week, so hopefully everyone's had a chance to take a look at them. If you would like to participate online, then you need to go to pollev.com and enter Ian David Joney, so Ian David Jones, but without the S, because I wasn't allowed that many letters, 636. And shortly, you will see some questions appear, and you can respond to those questions online, and then we can review the responses together. So what we'll do first, before we move on to the cases, is just take a look at an example. This is a case that we looked at in last month's film reading and also during the recent imaging day that I did for Linnaeus. It's a 2-year-old Great Dane presented as vomiting. Not necessarily something that you want to be presented with on a Friday evening if you're on call, because if you were presented with this case and this radiograph, then what you will see is a classic double bubble sign. So we have a little bubble just here, we have a bubble just here, and the smaller of these two bubbles is the pylorus. We've got some soft tissue segmentalization of the stomach, which is causing this double bubble or Popeye arm. And because we have the pylorus located in a dorsal rather than a ventral location, it should be located just down here in the cranioventral abdomen, we're already very concerned that this patient might be ending up on the operating table this evening. However, there are other things that we need to look at in this radiograph before whisking this patient off to surgery. So we've got two linear opacities within the dorsal-chordal thorax, which most likely represent the dorsal and ventral walls of the esophagus, which looks to be diffusely dilated. So that's certainly a pertinent radiographic feature and should appear in any radiographic report. And if we look closely at the lung, the area superimposed over the cardiac silhouette, just at the edge of this film, there are a couple of radiolucent branching structures, arborizing structures, if you will, that likely represent air bronchograms. So we've got a lesion within the pulmonary parenchyma. We've also got a lesion abnormality within the mediastinum, and the main concern, which is what's going on with this patient's stomach. As our eyes drift more towards the caudal part of the film and the mid-abdomen, you can maybe just comment on the position of the spleen. Maybe it looks like the body of the spleen is just drifting dorsally, so maybe a little displaced. And because, as I'm sure you have gathered we're looking at a patient that almost certainly has a GDV. The other thing that we need to look for is any evidence of gastric pneumatosis, so any evidence of necrosis of the gastric wall, and that would manifest as gas within the gastric wall. So we can see the wall of the stomach just here, and it doesn't look like any gas permeating the wall of the stomach. So there's no radiographic evidence of gastric pneumatosis in this film. So in summary, we have pylorus in a very abnormal location. So we're going to diagnose this patient with a gastric dilation and volvulus, all the classic features, the double bubble, the segmentalization, pylorus in the craniodorsal abdomen. We've also got a megaesophagus as well, and lots of patients that have GDVs can also have a megaesophagus. They can sometimes have a paralytic ileus, and that usually manifests itself radiographically as numerous loops of small bowel that are filled with gas. And because this is such a big dog, we haven't really got much of the abdomen included, but we can't really see any big dilated loops of bowel superimposed over the stomach in this patient's mid-abdomen. So there's no evidence of paralytic ileus, but there is some evidence of an aspiration pneumonia. So we've got some air bronchograms superimposed over the cardiac silhouette. If we can see air bronchograms, then that means that this area of lung, this lung lobe potentially, the right middle, is consolidated, has a ventral distribution, which is most compatible with a pneumonia. The fact that this patient has a megaesophagus as well means that it is probably aspirated, and that's caused this pneumonia, and this is an aspiration pneumonia. And we've got no evidence of a gastric pneumatosis. If we did, then that would mean that this patient, in all likelihood, had some necrosis of the gastric wall, and that would affect its long-term prognosis. The only other feature that I didn't mention during my description is most patients that have a GDV are also hypovolemic, and hypovolemic patients can have a small heart and a small chordal vena cava. It's difficult really to comment on the size of the heart because we've only really got the chordal 2/3 of the cardiac silhouette included in this radiograph, but subjectively the chordal vena cava looks a little small. So if you wanted extra points, then you can maybe comment on the size of that chordal vena cava, mentioning that it's a little on the small side, and that might suggest that this patient has a hypovolemia to go along with its GDV, its megaesophagus, and its aspiration pneumonia. So that is our example for this evening. So what we're going to do now is we're just going to test to see if our Poll Everywhere software is working. So I'm just going to activate the first question, which essentially is just, do you guys have any questions about this example? And if you are going to use the Poll Everywhere software, then use it now. Okay, so I can see a couple of you guys have responded, which is great. Okay, so what I'll do now is I'll just sync this up, and I'll see if your responses appear on my slides. I usually do, but no guarantees. All right, so let's move on. There we go. So 3/4 of you are happy, so you don't have any questions. So at least some of you have some questions. So yeah, if you guys have any questions about this example, then now is the time to ask them. So either via the chat or just be prepared to shout out and ask any questions. So any of you guys have any questions about this? I'm talking to the 25% that answered yes. No? Okay.
Sorry, Jan, I think it was me. I just pressed yes just to answer. So.
Okay, so
I did the same, sorry.
Okay, no worries. So I'll take that as 100% no, and nobody has any questions about this example. Excellent, which means we can move on to case number 1. So this is the first case for you guys. So this is a young, it's a large crossbreed dog, and it's presented to you as coughing. So you have I think 2 radiographs. So you have a DV thorax and you have a right lateral thorax. So yeah, any of you guys like to share thoughts on what you think might be going on in this patient? And this is probably one of the more straightforward cases of the evening. Not too dissimilar features in these radiographs to some of the features that we've already seen in the example of the patient with the GED. Anybody feeling brave? Because if nobody is feeling brave, then what I'm going to do is I'm going to activate the whole everywhere question for this case, which essentially asks you guys what you thought the most likely diagnosis was. So I've just activated that now. If nobody wants to present this case, then if you could answer the question online, then we can maybe discuss your responses. And this one, it's not a trick question. It was a really big dog actually. This one, I think it was something like 50, 60 kilos.
I mean, I can give a go. I don't mind describe it.
Yeah, go for it. Always better if you guys at least have a pop at the radiographic description and the diagnosis before we discuss it. It makes things a lot more interesting.
Okay, so there are two orthogonal view, a lateral, right lateral, and left lateral and D. On the lateral, you can see a diffuse alveolar pattern. There is like superimposed with the cardiac silhouette in the cranial. I can see air bronchogram like superimposed on the cardiac silhouette.
Yeah.
Then if you, so I will locate them in the cranial lung lobe. If you move to the orthogonal view, there is like an increased opacity in the right cranial lung lobe. I cannot see here a proper alveolar pattern, but I think that this area of increased opacity is like the same that is compatible with the one with the alveolar pattern that I see on the lateral view.
Okay.
If we go back to the lateral, the trachea seems a tiny bit like dorsally displaced, like and the cardiac silhouette, I would say it's borderline. Yeah, it's borderline. I wouldn't define like so enlarged, but I would say that it's borderline. Then as well, there is a diffuse, like there is this foci of alveolar pattern, but then there is as well in the rest of the lung parenchyma diffuse interstitial pattern as well.
Okay.
So my main differential probably would be like for this pattern, like a pneumonia probably. I think that like in dogs, cardiogenic edema is the distribution is like slightly different. It's like more peripheral.
Okay.
For me, it's not the classic distribution of like peripheral edema, of like cardiogenic edema, sorry. Yeah.
Okay. So what's your conclusion? What do you think this is most likely to be? Because that is essentially going to lead us into our online poll.
for me is like I would go for a pneumonia, most likely, probably.
Yeah.
If you assess, I cannot see neither like if I try to assess like the vessel on the lateral view, like I cannot really see them because like there is this superimposition with the pattern, but on the orthogonal view, they appear, they don't seem large.
No, they're kind of here. You can see them in the chordal lobes. Okay.
Yeah.
All right. So B is going to go for pneumonia. So I can see that 5 of you guys have already responded on the online poll. If anybody would like to change the response or to contribute to the online poll, do so now, and then we will take a look at your thoughts. So that's a good radiograph description, B, and we'll take a look at some of the features that you pointed out in just a second. Let's just take a little look-see at what our poll says. So a vast majority of you guys think that this patient has a pneumonia. So you agree with B. So B has convinced you about this patient's diagnosis. And I would also agree. So I absolutely agree that there is some evidence of consolidation in this right lateral view, and that is evidenced by the presence of these bronchograms. So again, we can see these branching gas lucencies. It is reasonably focal. I also agree that the opacity of the pulmonary parenchyma diffusely isn't entirely normal for a 2-year-old dog, so it's a little increased relative to what we might expect. But this view looks a little expiratory, so the increase in interstitial opacity that we can see in the dorsal-chordal lung is probably just secondary to this exposure being acquired during expiration. We certainly can't explain away the presence of these bronchograms in the cranioventral thorax superimposed over the cardiac silhouette as a result of atelectasis or expiration or anything like that. These are definitely pathological. The fact that we've got some consolidation, it has a ventral distribution, which, as B pointed out, fits more with a pneumonia rather than a cardiogenic edema. So not only cardiogenic, but non-cardiogenic edema in dogs tends to have a hilar and a dorsal-chordal distribution, whereas these changes in this lateral view have very much a ventral distribution, and that fits more with a pneumonia. In terms of, well, how likely do we think that this patient has primary cardiac disease? So if we were going down the road of, well, do we think that these changes might be secondary to a pulmonary edema, a primary cardiogenic edema, then we'd need to look for some evidence of cardiac disease in this patient. And in terms of the cardiac silhouette, I think it looks about the right sort of size. You might be tempted to say it's ever so slightly excuse me, enlarged in this lateral view, but it's really borderline. The shape of the cardiac silhouette, well, is normal, so I'm not really seeing any evidence of left atrium enlargement or any other specific chamber enlargement. And it's a young dog, so it's only 2 years old, this dog. As a general rule, big dogs tend to get DCM and small dogs tend to get mitral valve disease, and both of those primary cardiac diseases can manifest radiographically as a big left atrium. And the left atrium, if it was big, would result in the chordal border of this cardiac silhouette getting steeper, and this trachea and potentially the main stem bronchi being displaced dorsally. And we're not really seeing any evidence of any steepening of the chordal border of this cardiac silhouette, or really any tracheal displacement. B's absolutely right that you can't really see the cranial lobar vessels here, and that's as a result of some of this consolidation that we can see evidenced by these bronchograms. But there isn't really much in this view to suggest that these changes, this consolidation, is secondary to a cardiogenic edema. It's a focal consolidation. It has a cranioventral distribution. The cardiac silhouette looks normal. The rest of the lung looks reasonably normal. And on the DV view, the heart looks fine here. So, I mean, it isn't taking up any more than 60% of the width of the thoracic cavity here, so it's a normal size. The vessels in the caudal lung lobes look absolutely fine, so there's no evidence of any pulmonary vascular enlargement. And again, if this was a cardiogenic edema secondary to primary cardiac disease, we'd expect to see potentially some changes to the cardiac silhouette, and then the changes within the pulmonary parenchyma would have a different distribution. So it would be the caudal lungs that would be affected. Whereas here, as B has pointed out, there is this increased opacity within the left cranial lung lobe. So we've got the cranial part of the left cranial lung lobe, and then the caudal part of the left cranial lung lobe. And there's a very clearly defined margin between the two, and that probably represents a lobar sign. And a lobar sign is when you have a consolidated pulmonary parenchyma adjacent to gas-filled pulmonary parenchyma. But because of the difference in the densities, you get this very clean margin separating an area that has a more gas lucency, an area that has almost a soft tissue opacity. So in all likelihood, this is the caudal part of the left cranial lung lobe, and it's consolidated. If we were thinking, well, could it be that this dog has just a collapsed lung lobe? Is this just atelectasis? Well, the volume of this part of the left cranial lung lobe hasn't changed. It's about the same size. There's no associated mediastinal shift towards that area that would suggest that this lung is collapsed. So if you have a collapsed lung, an atelectic lung, then the heart is going to swing to fill the space created by the reduction in size of the collapse of that lung. There's no evidence of a mediastinal shift here either. The caudal part of this left cranial lung lobe is an abnormal size. It's not really any bigger, it's not really any smaller than we'd expect it to be, but it is way more opaque. And you just wonder whether there are a few little bronchograms, and you can see there are a couple of little linear gas lucencies that might represent late bronchograms. So what we got is a dog that has consolidation of the caudal part of its left cranial lung lobe, has a ventral distribution. The cardiac silhouette, pulmonary vasculature look normal. The remaining thoracic structures, including the mediastinal structures and the extrathoracic structures, look normal. This is a patient that's been vomiting, so it's not beyond the realms of possibility that this patient has aspirated a little. As a result of that, we've got an aspiration pneumonia affecting the caudal part of that left cranial lung lobe, which is what B suggested this was, and I would have to agree. So for me, this patient is most likely got an aspiration pneumonia. So good job, B. Anybody have any questions about case number 1? And essentially, good job, everyone, because the vast majority of you guys went down the pneumonia road as well, which is great. Okay, if there are no questions about case number 1, then we shall move on to case number 2.
I think that there is a question in the chat.
Oh, yeah, so there is.
Okay. Yeah.
Is there some retraction of the lung lobes on DV view? Let's go back and have a look. So retraction of the pulmonary parenchyma is something that we're going to see if there is a pleural effusion or a pneumothorax. So something within the pleural space that's pushing that pulmonary parenchyma away from the thoracic wall. So if there were a pleural effusion here, then we might expect to see some effacement of the borders of the cardiac silhouette. And I'm not convinced we can see any effacement of those borders in the lateral. We do see some effacement of the borders of the cardiac silhouette in this DV view. So on the right, we can follow the borders of the cardiac silhouette really nicely, and that extends towards the cardiac apex. And on the left here, just adjacent to what we suspect to be this consolidated part of the left cranial lung lobe, we do lose the borders of the cardiac silhouette a little, but that's most likely secondary to that consolidation rather than a small volume pleural effusion. I wasn't convinced I could see any retraction of the pulmonary parenchyma from the thoracic walls here. There are margins here and here, whereby we've got very radiolucent lung adjacent to lung that's not so radiolucent. In fact, is a little bit more opaque, and there are times when you might look at that and think, well, does this dog have a pneumothorax? This looks really radiolucent here, and it looks more opaque, a little bit medial and a little bit cranial to it. But this is probably just a margin of soft tissue. So it's probably the pectoral muscles and other soft tissues that's creating this margin. And I can't do it here for you because this is just a JPEG. But if you have a patient like this where you can see very radiolucent tips of the thoracic cavity and you're querying whether or not is there pneumothorax here, then essentially you just need to fiddle with the contrast a little and look for evidence of pulmonary architecture extending towards the periphery. So if you can see vessels, bronchi within the lung extending towards the periphery, then it's just lung essentially, and that change in opacity and that margin is just being created by the overlying superimposed soft tissue structures. There's also no evidence of a pneumothorax on this lateral view either, so there's nothing to suggest that this lung is being retracted from the thoracic wall. There's no elevation of the cardiac ceiling. So I wasn't convinced that there was any fluid effusion here. This little linear structure here is just the caudal mediastinal reflection. So yeah, that's nothing to worry about either.
Ian, is it possible that you see that type of thing when you've got dogs in troughs? Can that sometimes be positioning as well?
Yeah, absolutely. So if you're using positioning aids like troughs or potentially foam wedges, and part of the positioning aids are included within the area of collimation, then they can sometimes create little artifacts. So we had a cat today at the clinic where we had used some foam wedges that are usually used for positioning in CT to do some thoracic radiographs, and they just created little margins along the edges of the thoracic cavity that weren't a problem because I knew they were foam wedges, but you can sometimes get confused by those abnormal margins created by those positioning aids. So it's best to try and keep those out of the collimated area if at all possible. All right. Cool. Everybody happy? We can move on to case number 2, which is an 11-year-old male neutered domestic short hair that's presented to you with strangulation. So this is just a single view. So again, I'll open up the floor and I will see if any of you guys are happy to have a little chat about this one. So we've got just a single lateral radiograph of the caudal abdomen of this cat that's straining to urinate. And this is absolutely something that you guys are likely to see in first opinion. Anybody fancy just walking me through some of the key features of this radiograph? If nobody is up for it, then I can talk a little bit about some of the key features, and then I can ask you guys if there's anything else about this patient that you might want a little bit more information on. So, nobody up for case number 2?
Ian, I can have a go.
Yeah, go for it. Thanks, man.
Okie dokie. We have a lateral projection of an abdomen, and I'm not. Do we have another view as well? I can't remember.
It's just this one for the time being.
Fine. Cool. So we have some implants in the pelvis, which we can see on the top of the X-ray. It seems to me that this is mostly just the caudal abdomen. So you know that there's clear particular interest in the urinary system. From what I can see, we have bladder and we have kidneys kind of in the top left-hand corner and some intestines as well. I guess the biggest thing that I can see is this kind of we can see these kind of calcified structures within the urinary bladder. So I guess I would be strongly suspicious that this cat has some urinary stones. I guess our kind of next step could be that we could either do an abdominal ultrasound, or we could be doing contrast studies within the bladder. Yeah,
absolutely. Yeah, good job. So I absolutely agree. I think the key radiographic features here are these clearly marginated mineralized structures within the lumen of the urinary bladder, and they are numerous, too numerous to count. Not only do we have these clearly marginated mineralized structures that look like discrete structures, we've also got this mineralized area within the dependent part of the urinary bladder, which is also very abnormal. The bladder itself looks reasonably full. There's a little area within the center of the bladder which could represent a little air bubble, maybe. The rest of the abdomen looks pretty normal. We can see the colon, we've got the kidneys, we've got the small bowel, which looks fine. So just a single population small bowel, a little bit of gas in it. It's all clumped in the center of the abdomen, which is normal for a cat. The abdominal wall looks fine, and there may be a little bit of spondylosis affecting some of the lumbar vertebra, but we're reasonably happy with the lumbar spine. There are some metallic implants here, so this cat has certainly had something happen to it in the past and has had some orthopedic surgery. So these little mineralized structures within the urinary bladder are compatible with little cystoliths, so we can be really confident that this patient has a cystolithiasis. And not only does it have lots of little tiny discrete cystoliths, it also has a bunch of mineralized sediment within the urinary bladder as well. It's really tricky to see stones in the urethra of cats, but it's always worth taking a look. So if we look at the margins of the urinary bladder and we follow it up towards the trigone where it tapers, the urethra is going to be in this sort of area here, and most of it is superimposed on the pelvis, which is why Luke suggested potentially doing a contrast study here, so a retrograde urethrocystogram. But even in a plain film, it's worth taking a look to see if you can't see any evidence of any stones within the urethra. And I don't think you can here. So this is a pretty straightforward radiograph. It's a cat that has bladder stones, which is all well and good. The reason why I decided to pop this one in is just to see if you guys saw anything else about this radiograph that you might have been concerned about. So I'm going to just activate the next online question. This question refers more to the musculoskeletal system, the bony structures, rather than the abdomen and the bladder. So I just want to ask you guys, how many legs do you think this cat has? We've got a couple of you responding, which is good. All right, so let's just sync this up and see what you guys thought about this cat's hindlimbs. Okay, so I gave you the option 1, 2, 3, 4. I mean, really, we've only got one radiograph, and even a normal cat, you'd only be able to see 2 legs. But let's see what you guys made of it. So we've got quite a few of you saying that, well, we can only really be sure that this cat has got 1 leg because you can only see 1 leg in this single radiograph. And then we've got the rest of you saying, well, I think there's a missing leg. So it would be unusual to have a 1-legged cat. So this cat probably has 3 legs. And I'd absolutely agree. So this is something that I've been caught out by previously, particularly during my residency, is missing the fact that a patient is missing a leg. And there's also something called satisfaction of search, where you see the lesion that you think is responsible for the patient's presenting clinical signs, and then essentially you stop looking. So in this film, we can see the bladder stones. The cat has presented because it's straining to urinate. The bladder stones would absolutely explain the reason why this cat's presented. So we're happy. We think we made a diagnosis. It explains why the cat is here. So we can nip off and get a cup of tea. And if you were to do that and miss the fact that this cat is missing a leg, then that would be an example of satisfaction of search. So we are clued into the fact that this cat has previously had some orthopedic surgery related to its pelvis because it's got this metallic plate implant and then this screw. And we can only see one leg here. So we've got one femur and one tibia and fibula. And there is another one. There is effectively a leg missing. So yeah, well spotted, everyone. So it's easy to tell if there's a leg missing with an orthogonal view. And that is the orthogonal view in this cat. Much harder to see the bladder stones in this view, but much easier to tell that it is in fact missing its left hind limb. And easier to assess this cat's metallic implants. So it's got a plate on its left ischium and numerous screws, as well as a screw going through its ischium. It's got a circular back screw as well. So that was a little bit of fun, just to remind you guys not to be too satisfied about making a confident diagnosis, not to fall into the trap of satisfaction search. And even if you see what you think is the primary lesion and the reason why the patient is presenting quickly, and you're confident about that diagnosis, make sure that you look at the rest of the film. There aren't any other features on that radiograph that you need to report. I know that if you had the cat in front of you and you were taking these radiographs, you're not going to miss the fact that it's missing its left hind leg. But if you are doing teleradiology, for example, you're just looking at films that your colleagues have presented to you, they might have neglected to say that the patient is missing its left hind, and it's possible to look a little silly if you don't mention that in your radiographic report. What it is worth doing is just taking a moment to look at an ultrasound image from this cat's bladder. So this is just a single image. It's acquired using a high-frequency linear probe. This cat's bladder is very small, so this is the bladder just here. So there's not really very much of it. And what we can see in the lumen of the urinary bladder, which is just here, are these multiple small hyperechoic structures that have this associated acoustic shadowing. So these are the little cystoliths that we can see on the single chordal abdominal radiograph that we've just reviewed, so that effectively confirms our diagnosis. The rest of this very hyperechoic particulate material probably represents that mineralized sediment that we can also see on the radiograph. We talked a little bit about looking for urethral stones. So the vast majority of these cystoliths are present within the lumen, and as we look caudally, so towards the right-hand side of the screen is going to be towards the caudal end of the patient. So the trigone is going to be over here somewhere. We've just got one stone that is just thinking about making its way towards the urethra. So there's a single, small, clearly marginated hyperechoic structure with associated acoustic shadowing, just cranial to the trigone, just thinking about going towards the urethra. So when you pop a probe on these patients, you can't see all of the urethra in cats and in dogs, particularly all the female dogs that have very caudally positioned bladders. But sometimes you can see some of the urethra. I can give you a little bit more information about where these stones are likely to be, particularly if you're thinking about doing a cystotomy. You don't want to leave a stone behind, so you don't want to cut into a bladder, remove all the stones from the lumen of the urinary bladder, and then leave a stone in the urethra. The best way to be absolutely certain that you haven't done that is to do a retrograde urethral cystogram, but doing an ultrasound can clue you in as to how concerned you should be about sneaky little cystolets making their way into the urethra after you've catheterized them and blocked them and flushed them and removed all of the stones from the urinary bladder. Okay. So there we go. That was just a kind of a fun one, really. Well done for noticing the missing leg. Does anybody have any questions about this case? And you can do that via the chat if you like, or you can shout out. If not, then we will move on to case number 3, which again is it's a cat. It's a young cat this time, a male neutered domestic short hair, and was presented with an acute onset lameness of its right hind. So I gave you guys 2 radiographs to take a look at. This is a little bit sneaky, this one. Anybody fancy taking on case number 3?
I'm really fancy to do it because I don't know what it is.
Yeah, go for it. This is a sneaky one.
Okay, there are 2 radiographic projections. One is a VD and the other one is a right lateral, which is not really useful, of the pelvic of a, I will say, almost skeletally mature cat, as the tibial crest physis is still open, but is a normal, is considered as a normal condition for the age of the animal considered. So we can see a really mild decrease of the soft tissue musculature, mainly within the medial aspect of the right limb, and focus on the femoral head of the right pelvic limb. We can see there is a really small focal sort of speculate new bone projection on the ventral aspect of the femoral neck. And if we move on the trochanteric fossa, there is a really, really subtle new bone formation there as well. It's quite smooth. The appearance of the femoral neck, it looks a bit, the angle, it looks a bit more sharp to me, like a sort of sunglass appearance, okay. If you know what I mean. And I'm not sure if I can see a sort of really focal and subtle radiolucency, just at the level of the ventral aspect of the femoral neck. Okay. I cannot really see any other dodgy area in the spine or within the pelvis. So I'm not really sure what it can be, what we can put in differential diagnosis. I will probably, it's going to be like a sort of open diagnosis, and I would really ask for more like advanced imaging, like a CT. However, I will possibly put trauma, osteomyelitis, possible tendinopathy, and I don't know if it can be a sort of early stage of femoral neck metaphyseal osteopathy, but I don't really know.
Okay, yeah, no, that's absolutely fine. Yeah, good job. So what we're going to do now is, based on Nicoletta's excellent description, we are just going to open up the floor. I'm just going to ask you guys just to point to where you think the problem is. So if you agree with Nicoletta, then you should be homing in on that right femoral neck. If you think there's something else going on somewhere else that might explain this patient's right hind limb lameness, then you can point to it on the pole. And then we'll sync everything up and we'll see if we are all in agreement about which area we think is most likely to be causing the problem. Okay. So just out of interest, Nicoletta, if you were going to take some more radiographs, are there any particular radiographs or radiographic views that you would recommend here?
Well, probably mediolateral of the femur, just of the right, so we can better see essentially the femoral head.
Yeah.
I'm not sure if a craniocaudal of the femur can be useful in this case.
Yeah. Okay. So let's have a look, see what you guys thought. Yeah, so you did a pretty good job of convincing everybody that that is where the problem is. So that right femoral neck, and I absolutely agree. So in terms of description, I think it's spot on. So I absolutely agree with you describing this as looking like a little bony spur, and I think that is effectively what it is. But I would just invite everybody just to take a step back and just look at the thickness and the length of the right femoral neck versus the left femoral neck. And I would just put it to you that the right femoral neck looks a little bit shorter and a little bit thicker than the left. And with that in mind, I just follow the margins of this right femoral head and neck. So the margins of the right femoral head look contiguous up until you get to the point where we have picked up this little bony spur. And if you look at the margins of the sort of femoral diaphysis just adjacent to it, those margins look pretty contiguous up until you get to the point where we've seen this little bony spur. And if we focus in on this area in a little bit more detail, you just wonder whether or not that it might be just a suggestion that there's a little fissure line just bisecting this right femoral neck. And this little bony spur might represent the edge of what would be a fracture fragment. The fracture fragment in this case consisting of the right femoral head and the adjacent, and if this is a fracture, non-displaced fragment being the remainder of the femur, so the remainder of the femoral neck and the femoral diaphysis. So that's something to think about. Is there a little fracture here? And certainly something to think about as we look at the lateral view. So I agree that 9 times out of 10 lateral views are pretty useless when you're trying to assess the coxofemoral joints. Super useful to help try and describe pelvic fractures. So lateral views can be really useful to try and describe how fragments are displaced. You usually have to look at the orthogonal view, and that's why we recommend doing lateral as well as a VD pelvis. But usually when you're looking at hips, you really want to look at the VD views, and the lateral views are not really very helpful. But here, when we can see the 2 hind limbs, and we can see one hip joint, which is just here, and we can see a femoral head, which looks like it's fitting nicely within the acetabulum. And then if we look at the other, we've got a femur which is just here, and we've got a femoral head which is just here. And you just get the impression that there's a little bit of daylight between the two. So there's a little margin here that shouldn't really be there. And that little margin just tapers to a point, and then is contiguous with the margins of the femoral head. And really this femoral head, probably the right femoral head, should look completely contiguous with the femoral diaphysis that's just adjacent to it. And it doesn't. It looks like there's a little gap between the two. And if we try and marry that up with the changes that we've seen in the VD, we've got this little bone spur here, which we're already suspicious could represent the edge of a fracture. It could be that this little bony spur here is just the little edge of the femoral head here, and that little area where it's tapering. So the answer here is absolutely that this right femoral neck is where the lesion is. So you guys nailed it in terms of the lesion is affecting the right femoral neck, but this can has a fracture. So this cortex here is discontiguous, and there's a little tiny fissure line which is bisecting that right femoral neck. And even though there is very mild displacement of the composite fragments, this femur is displaced slightly medially relative to the femoral head, which is why this femoral neck looks a little bit thicker and a little bit shorter relative to the left and the lateral view. And that's why we can see a little bit of a gap between this, what is the right femoral head, and the rest of the femur. Now, in terms of how can we see this a little bit more easily. And if we'd done a frog leg view here, I think that would have shown it up really nicely. Now, I don't have any other radiographs, unfortunately, to show you, but I can tell you that this cat was taken to surgery. It did have a fracture of its right femoral neck, and it did have a femoral neck excision, and is now doing really well. So the reason why this this case is in here is just sort of to point out how tricky it can be sometimes to see fractures affecting the femoral head and the femoral neck in cats. This cat's got a fracture of its femoral neck. Lots of skeletally immature cats that have Salter-Harris fractures affecting their proximal femur, their femoral head. It can be really tricky to see them when you just have a VD view of the pelvis with the hind limbs extended, because by extending those hind limbs, you sort of slot all of the composite fragments back into place, which means that they're minimally displaced, which means it's really hard to see them. Whereas if you have a frog leg view, then that distracts the composite fragments really nicely and makes them really easy to see. So the reason why this case is in here is because it's a challenging case. It's hard to see the lesion and to know exactly what it is, and also to demonstrate to you guys how useful a frog leg view can be in these young cats that have acute onset hind limb lameness, and you've localized the lameness to the hip joint. A frog leg view can be super helpful. It can really help show up Salter-Harris 1 fractures affecting the proximal femoral epiphysis and also femoral neck fractures as well. So yeah, this was a really challenging one. Yeah, I think you guys did a really good job of describing it. So yeah, good job, Nicoletta, focusing on this right femoral neck. That's absolutely where the lesion was. And it's really tricky to see. And yeah, this is a young cat, acute onset hind limb lameness. And this cat had a non-displaced fracture of its femoral neck, and yeah, did really well with the femoral head neck excision. And the thing to take away is that if you have a cat, you think it has a fracture affecting its femoral head or femoral neck, and you're really struggling to see the lesion, then a frog leg view can be super helpful, because that is going to help distract the composite fracture fragments and make them much easier to see. All right. Cool, nice job everyone, and good job on the poll everywhere as well. Everybody was concerned about this femoral neck, which is great. Anybody have any questions about this one? This was a tricky one. This was certainly the hardest case of the evening, I would say. Oh, I see Rosa said that she was in a frog leg. Yeah, good job, absolutely. Okay. So if everybody's happy with number 3, we shall move on to the last case of the evening, which is a 4-year-old female neuter domestic shorthair, and is presenting with a chronic left hind limb lameness this time. So I gave you guys a couple of radiographs to have a look at, just the 2, in fact. So it's probably a VD, not the best positioned radiograph in the world. So this is effectively a frog leg view, so that would have shown up the fracture in the previous case really nicely. Then we've got a medial-lateral view of this left femur and tibia and the remainder of the distal limb. So not the best radiographs, but certainly worth taking a look at. So anybody fancy going through what you think you might be able to see on the radiographs of this pussycat that has a left hind limb lameness? And this one, there's no tricks with this one. This one is a little bit more straightforward.
If no one wants to do it.
You're a glutton for punishment, Nicoletta. Thank you very much. Yeah, if you did.
I mean, if no one, someone else, no.
Yeah, I mean, it would be good. I mean, I think you get the most out of these sessions by contributing and presenting the cases. Nicoletta has very kindly agreed to present another case. If nobody else wants to have a chat about this case, then yeah, we'll let Nicoletta give us another radiographic description of case number 4. Any other takers? I think.
Don't be shy.
I think it's going to be you again, Nicola. So thank you very much for doing 2 cases. Much appreciated.
It's my pleasure. Okay, so we have 2 radiographic projection, one sort of VD frog leg, and the other one is a mediolateral of the left femur of a skeletally mature cat. So in the VD, we can see that there is an increased opacity of essentially the musculature of the left thigh, which looks swollen to me compared to the contralateral. There is a change in the bone radiopacity within essentially the femoral head and the femoral neck, with mild remodeling and resorption of the femoral neck, a sort of apple core appearance. There is a possible focal radiolucency within the ventral aspect of the femoral neck, together with a sort of really faint fissure line that he runs essentially through the femoral neck, and there is also resorption of the lesser trochanter compared to the contralateral limb. So my potential differential are essentially a late stage of slip femoral capital physial fracture.
Okay.
Yeah, I mean, yeah.
Yeah, no,
I will
yeah.
put this as a first,
Yeah.
my main differential diagnosis, essentially.
Okay. No, I think that's a good shout. I liked your radiograph description, and hopefully everybody else liked it too. So what we're going to do is we'll just activate the final online question for the evening. So Nicoletta has pointed out the soft tissue swelling that we have here. So if we compare the opacity of the proximal right hind to the left hind, it's increased in size and far more radiopaque on the left relative to the right. So certainly something going on within the soft tissues of this proximal left hind limb. Not only that, but Nicoletta is suspicious that there's also something going on with the bone. So there's a suspicion that there could be some lucencies affecting this left femoral neck, so some evidence of some bony destruction, some cortical destruction. So my question to you guys is, do you agree? Do you think that there's any bony involvement here? Because if there is bony involvement, then that changes our list of differentials and the things that we might consider as being the cause of this reported left-handed illness. So let's just take a look and see what you guys thought about the bone and whether you agree with Nicoletta. So we'll just sum those up. Oh, 50-50, okay. So not everybody convinced that there is any bony involvement here. So yeah, that's interesting. So in terms of the radiograph description, I do agree with Nicoletta. I do think that this left femoral neck is abnormal. If you compare the radiopacity of the left femoral head and neck with the radiopacity of the right, it's much more heterogeneous, and there certainly is the suggestion that there's at least one focal area of lucency, and also the margins of this left femoral neck and femoral head look a little indistinct relative to the right. Now that could be because of whatever's going on in the soft tissues here. So there's certainly a huge amount of soft tissue swelling that is more than likely related to whatever is going on in the bone in this femoral head and neck. But in all likelihood, there is some bony involvement. The only other area that I was a little concerned about when I looked at these radiographs was just the acetambulum. So if you look at the opacity of the acetambulum on the left relative to the right, then it looks like it's a little reduced on the left. Now you've got to be super careful about making those calls, because you've got the acetabular fossa and notch here that can look a little bit more radiolucent. And if you haven't got a completely straight pelvic radiograph, then it can look more radiolucent on one side versus the other. So it's possible to overread pelvic radiographs and come up with lesions of the acetabulum when in fact it's just the fossa. But here the pelvis is pretty straight, really, considering how wonky these hind limbs are. And it does look like there's a little bit of reduced opacity in this right acetabulum, along with this femoral head and neck. So let's take a look at some advanced imaging. So we're going to take a look at a CT. We haven't stopped to admire this medial lateral view because there's not really much else to see on this medial lateral view. We don't have the right hind limb to compare this to. Really here, it's just the soft tissue swelling. So all of these soft tissues look really thickened and opaque. So 50-50 in terms of bone involvement or not. So let's just take a look at so this is going to be a 1.25 millimeter post-contrast soft tissue reconstruction of this cat's hind limb. So I'm just going to play this for you. So right from the get-go, something that I'd like to point out to you guys is the fact that we've got a very abnormal ventral subcutis on the left here. So if you look at the ventral subcutis on the right, it looks pretty normal, has a fat attenuation. On the left, we've got an increased attenuation, and it has this very wispy quality. And that's something that we often see with edema. So if you have cutaneous edema, that usually manifests on CT as an increase in attenuation that looks very wispy. So already we're thinking that this could be something pretty sinister going on here to cause that. So we're moving caudally, and now we're getting to this mass lesion. So this mass on this cat's leg was humongous. So obviously at an advantage relative to you guys in terms of thinking about differentials. So we had this cat in front of us, so we knew there was a giant soft tissue mass associated with this cat's left hind limb. You guys just had the radiographs to look at, so you didn't have the benefit of seeing just how huge this mass is. But one of the reasons why I've included this is just to point out to you guys how a giant soft tissue mass associated with a hind limb can look on a radiograph. So there are changes on the radiograph, but they're not that impressive. On the CT, way more impressive. So we've got this huge lobulated soft tissue attenuating mass associated with the proximal left hind surrounding this left coxofemoral joint, which is just here. And it's got a really interesting enhancement pattern. So really strong peripheral enhancement, and then really, again, sort of wispy central enhancement. It almost looks like it's extending little septa from the center of the mass towards the periphery. So that doesn't really help us in terms of coming up with a differential list here, because there aren't really any soft tissue masses that have this appearance typically, but it does look like it's centered around the joint. So that might influence us in terms of what type of mass we think this is most likely to be. So that edema that we mentioned earlier, because this cat has got this giant mass, we need to potentially think about a reason why this cat might be developing a ventral edema. And not only does it have a ventral edema on the left affecting its abdominal trunk, it also has edema affecting its hind limb as well. So just here, we've got the external iliac vein, which is just here. Sorry, this is the deep circumflex iliac, and on the left, it's a little bit enlarged relative to the right. On the right, it's tricky to see. And if we move caudally, so So here we're now starting to look at the external iliacs. So this just here is the left external iliac vein, and it's being squished by this huge mass. So this left hind limb, it's not able to, the venous drainage from this limb is being impaired by this mass because it's squashing this left external iliac vein. As a result of that, we're getting some edema formation. And not only that, but we've got a whole bunch of really enlarged collaterals. So if you guys just look around the periphery of this mass lesion, there's a whole bunch of enlarged peripheral vessels. So these are little collateral vessels that have opened up to drain this left hind limb because the left external iliac vein can't drain it because it's being squashed by this mass lesion. So we've got this huge soft tissue mass that's associated with the left coxofemoral joint. It has a really pretty enhancement pattern. That doesn't really help us decide what this is most likely to be, but we can be pretty confident that this mass is so big, it's impairing the venous drainage from the left hind. The other thing that the surgeon would like to know is, well, do we think that this mass is invading the pelvic canal, because that might affect whether or not we can remove it, and it absolutely is invading the pelvic canal. So we've got the pelvis here, this is the pubis, and this mass is inside the pelvic canal. So it's unlikely that we're going to be able to remove this thing without really removing the entire left side of this cat's caudal abdominal trunk and left hind. So we'll just take a little look at a bone reconstruction as well, because one of the questions that I asked you guys is whether you thought there was any bone involvement, and we had a 50-50 split in terms of whether the bone was likely to be involved or not. So let's come back to this left hind. So if you guys take a little look at this left femoral neck, which is just here, you can see there's certainly some evidence of bony destruction here. So we've got multiple punctate lucencies permeating that left femoral neck. That lesion we could see in the acetabulum on the radiograph was real as well. So if you compare the attenuation, the density of the right acetabulum versus the left, and this left one is very much reduced. So for those of you and Nicoletta who were convinced that there was some bony involvement, you're absolutely right. So not only is the femoral neck involved, so we can see that cortex as well, that ventral cortex of the femoral neck is a little bit discontiguous. There's also some evidence of lysis of the acetabulum as well. So just here, we can see that cortex is not completely contiguous. There's some destruction of the bone there. So we did some biopsies of this mass. The pathologists were really cagey about what this was most likely to be. I think it, in terms of the suggestions, I think carcinoma was high on the list. So like a synovial cell sarcoma, carcinoma, I think was high on the list for the pathologists here. So yeah, we don't have a definitive diagnosis, but certainly something bad that is invading the pelvis and the left femoral neck, and is going to be impossible for us to resect, because not only is it invading the bone, it's progressing inside the pelvic canal as well. So yeah, nice job. Anybody have any questions about case number 4?
Ian, sorry,
Yes.
would you put a differential liposarcoma with that type of
Liposarcoma.
contrast enhancing?
Yeah, so I suppose the reason why liposarcoma was not on the list is because the mass, I haven't given you the soft tissue pre-contrast reconstruction. It wasn't fat attenuating. And a lot of the liposarcomas that I've seen have been predominantly fat attenuating, so they have a negative house fluid unit value, and then they have more soft tissue attenuating component. And you're absolutely right that a lot of liposarcomas, they have central soft tissue attenuation that looks kind of wispy. But because this had a more uniform soft tissue attenuation in the pre, I think liposarcoma was further down the list of differentials. But I think it's a reasonable suggestion. Anybody else have any other questions about this case? So there's no intertarsal joint. Let's take a look. Presumably that's on the RADS. So if we look at the tarsus here, so we're just querying whether or not there's any evidence of any luxation affecting the tarsus. So I'm reasonably happy. I'm maybe looking at this area here, which is the proximal intertarsal joint. I think that looks fine. I'm not convinced there's any subluxation there, but difficult to tell just with this medial lateral view and then a really wonky frog leg view of the pelvis in terms of where these handlings are. Okay. Anybody else have any questions about this one? So the main findings here: loads of soft tissue swelling and abnormal bone. If not, then that is all of our cases. So that's our 4 cases, and that brings us to the end of the evening. So yeah, if nobody has any other questions about any of these cases, then I will say goodbye and hope you guys enjoy the rest of the evening. I've run over slightly tonight, so apologies for that. Yeah, I hope you enjoyed all the cases.
Thank you.